in Rome or in London. Totally different, the way of proceeding. So we have these three phases. In the first one, we have reviewed the state of the art. In the second one, we are going to assess which are the priorities of the member states, depending upon the current status of how they are approaching frailty. We will propose to them some roadmap, depending on their status and what are their priorities. And in the third year, we will make again a new consultation with the aim of releasing final roadmaps for each country. We are now trying to classify them upon the information we have collected during the last year. We have released this state of the art. This state of the art in some way reflects the opinion of Europe about frailty. Remember, for policymakers, we are not here making scientific ways of the role of troponin T in define. No, it's for policymakers. This is also, in addition with this state of the art that you can download in this webpage, we have also sent a summary to the Journal of Nutrition, Health and Aging that will be published, I don't know when, but it has been admitted, and we have asked to the editor for a fast track publication. These are the 13 questions we have tried to answer in this state-of-the-art document. What is the definition of frailty? What is the relationship between frailty and multimorbidity? How common is frailty in the Advantage Joint Action member states? How many new cases should we expect in the future? Can a frail person improve his/her situation spontaneously? How can frailty be screened and diagnosed? How can frailty be managed? It is necessary to screen frailty at population level. Is there a need to monitor frailty along Europe? What components should health and care system adopt to manage frailty? Is now this workforce ready to meet the challenges of frailty? And what are the future areas of research on frailty? These are the 13 questions we have tried to answer in this document about the state of the art of frailty all over Europe. These are sorry for the quality of the slide. These are the 5 work packages, each of them approaching one or several of these questions to be answered. First one, frailty definition, individual screening and diagnosis, epidemiology of frailty, population screening, monitoring and surveillance, prevention, clinical management from a personal point of view, and work package 7, care models for frailty management. And the last one, work package 8, regarding education, training, and research about frailty all over Europe. These are the documents we have assessed. We have taken documents not only from the usual PubMed, IC, or other sources of information, but also regarding what is usually called as GRI literature. We have asked to the regional, national, and local governments to send to us any document that they have released about frailty, and for doing so, we have had the valuable help of the people in the member states that have approached the national, regional, and local authorities. So at the end of the day, we have reviewed more than 1,200,000 documents. From this huge amount of documents, we have analyzed more in depth 500 of them. So the conclusions that I am going to show to you comes from these 500 documents. We have made some the main part of the work has been done by the work packages. We built a first draft, and then we have a meeting in Menorca, in Mahón, at the end of September, with our external expert panel. These are some members of the working groups, but also some members of the external expert panel, Stefania Maggi from Italy, Joao Pinto from the Commission. This is an expert in family physician coming from Spain. So we have this mixed panel where we will the final version of this state of the art. Although you see that the weather was nice and it's in Menorca, it's in Balear Islands, I promise you that we spend all the time working, all the time. In addition, we have provided some glossary of terms. You know that one of the problems when you talk about frailty, as Jeremy has raised, is that people think different things. So sometimes you are talking apparently about the same thing, but in fact you are talking about different things. So now we have a glossary of terms that includes active aging, what is assessment, what is disability, but also what is frailty. And frailty, in this document, is defined as a geriatric syndrome which can be regarded as a quite close to the definition by the WHO. And this is also, in some way, not only a scientific decision, but also in some way a political decision. I like more the definition that we did in the document of the Delphi consensus. But probably to join the same definition that the WHO has raised is, from a political point of view, a better approach to convince to policymakers what about you are talking. And this is why, although there are some terms in this definition that I would like to include after in sometimes strong discussions, I think that we have agreed a nice definition about what frailty is from a not only a scientific purpose. Sorry for insisting, but I think this is very important to have in mind, but also for policymakers that are the one in charge of implementing policies everywhere. We made also some recommendations for of people who are frail, pre-frail, or robust, it's highly sensitive to changes. For instance, changes in only 5 points in a scale that goes from 0 to 105 changes your risk for death, incident disability, and hospitalization in 3 years. So it's quite sensitive. And probably using these instruments, we will be now in conditions to assess frailty trajectories, because it's a high sensitivity instrument. And in addition, we have proposed a very simple scheme on how to manage frail older people. This is the algorithm proposed by Advantage to detect frailty from a diagnostic purpose. And here in the right part of the slide, you can see 1, 2, 3, 4, 5, 6, 7, 8 measures to be adopted when you detect that somebody is frail. Very simple things, very clearly established things. Of course, in the audience, and why have you not included, when we have detected any significant controversy, we have excluded these recommendations. These recommendations, all of them, are heavily supported by a big amount of evidence. And it includes when comprehensive geriatric assessment must be done, when should be assessed frailty and pre-frailty when you are assessing diseases, how the exercise program can be implemented and the main components, which is the instruments we should to be used to assess nutrition, taking into account that many of these measures are done thinking in primary care. We should also assess drugs and polypharmacy. We should advise patients to decrease his or her body mass index if it is higher than 35, but also it is lower, it's not here, but lower than 20. Consider vitamin D supplementation in frail patients at high risk for falls and with a vitamin D level lower than 30, with doses of 20 to 25 micrograms per day. And we made a last consideration about the potential usefulness of ICT solutions. And this is the consensus we have made. I'm pretty sure that all of you are missing something here. Me too. So now we are facing the phase 2. We have collected many information about from the member states. Next week, we will have a meeting in Treviso, in Italy, organized by Graziano Onder and Roberto Barnabei, the groups of the Università Cattolica del Sacro Cuore, and we are going to discuss the documents, the information we have received, with the aim of, at the end of the year, release another document with the information on how is the current status of frailty approaches in the countries of the European Union, what are their preferences, and how are we going to approach this in order to develop roadmaps for all of them. So we are trying...
Five minutes?
Yes, it's my last slide. We are going to approach the changing, what we have called in an editorial that we published in JAMDA last year, how are we leading in Europe the clinical transition after demographic transition, after the epidemiological transition. Now is the time for clinical transition. A clinical transition that should move the way of doing things from this conceptual framework to this new conceptual framework, where care is more important than cure, where function is more important than disease, where quality of life is more important than survival, when risk-to-benefit ratio is more important than to do anything, with intervention should be provided timely, because older people do not have all the time to experience benefits and problems, where prevention is much more important than reacting, and where integrated and continued care is the basis for providing a good care for all the people in general and for those who are frail particularly. So again, we are trying to face the true challenge that is disability. And for doing so, we need to fight against frailty. And this is the main aim of Advantage. So thank you very much.
Thank you very much, Dr. Rodríguez Mañas, for your inspiring talk. We can have, I think, 5-10 minutes for discussion. If you want to talk in Spanish, we will translate, no problem. Si queréis hacer las preguntas en español, lo traduciremos sin problemas.
María Eugenia Soto from Toulouse. So first of all, thank you so much for your both talks. They're great. And this is a question for the both of you. Maybe it has been already discussed during the meeting. I don't know, because I became late yesterday. Concerning the latest recommendation, WHO latest recommendation about healthy aging and about the 5 intrinsic capacity, which is the connection. I can see the connection, but which is really the connection between that and maintaining, relenting, and preventing frailty? Is that continuous? Is that, you know what I'm saying? Is that these 5 capacities should we work on the robust state? Thank you.
I think in the clinical world, when you're faced with real-life patients on a day-to-day basis, I think you have to take all of these things into account. It's difficult. When there's big policy decisions, it's great to sort of think about overall directions, but when you're looking at a patient, I think you have to make some quick judgments, and I think you have to think about where they are in the trajectory, in their pathway, and if they're in the frail category already or quite disabled, then you manage them very differently. Beyond that, I don't know how to integrate the WHO things. I think one of the things that we notice in the United States, and it's probably we see this when I come over here, there's a lot more sort of big picture policy direction things happening in the EU and in the WHO, and in the States we don't sort of think much about that. And not that it's bad. I think that we're not doing more proactive planning. We tend to be more of a sort of survival of the fittest kind of society rather than the big conceptual framework. So I don't know, Leo, do you have any?
Rompas, creo que hay que pagarlo. I think that from a policy perspective, I think it's good to be aligned with the World Health Authority. This does not mean that we share all the concepts that WHO is managing. But Jeremy has told about resiliency. And WHO is promoting the term intrinsic capacity. Why not continue talking about frailty?
That's my question. That's what I don't understand.
Yeah, but Jeremy has told, because it's unpopular. It's not a good term. People does not like to be frail. And if you want to capture the attention of all the people, and not so all the people, to prevent frailty, you can probably move to other more positive concepts or more positive words. And this is why probably now we are moving but at the end of the day we are talking about the same thing, because what we want to do is to detect, to prevent, and to intervene on people at high risk for disability. The final focus of all of us is to avoid disability. When you detect hypertension, I'm not interested in hypertension per se. I want to prevent myocardial infarction or stroke. Why? Because when you have a stroke, there are few possibilities to improve you significantly. While if I put the focus in hypertension, I have high possibilities to avoid a stroke. This is a quite similar approach when we are putting the focus in frailty. And frailty is a stage in the pathway from robustness to disability. You can say that the step is this, or depends. The discussion is when you should detect and when you should approach. But we are talking the same things with different words. I don't know if you agree.
Yeah, I would agree with that. I think sometimes for patients, at least in the States, it's simple words are a lot better, so words that are compelling, and it's really a kind of a public health mission kind of thing. So words like intrinsic capacity to a patient, at least in the States, would mean nothing. They would have no idea what anyone was talking about. So I think it's important for clinicians to understand those big policy initiatives, but to use words like frailty. We want to prevent you from getting frail. Or words like robust. We want to keep you robust. You're doing great. You're very resilient, and these are the ways that we can keep you there, or move you back in that direction. So I think it needs to be aligned, but at the same time, I think on an individual basis with your patients, you have to use those more granular, meaningful terms.
In fact, we have, when you, for instance, assess the relationship between many biomarkers with frailty, and you put this the relationship between these same biomarkers with intrinsic capacity is quite close. It's quite close. So I think we are working on frailty, but from political perspectives probably is better to use a more proactive, but at the end of the day, I think we are working the same thing.
Okay, thanks.
Dr. Avizanda. Allí.
Thanks. Pedro Avizanda from Albacete, Spain. Thank you very much for your invaluable work and your presentations. Yesterday I presented some data from the FRADEA study showing that those that are already frail have a very, very high risk of adverse events, very close to those that are disabled, and that really those that have an intermediate risk are those that actually we call them pre-frail, that I think it's a very broad category of people that really have, they are already good, but with a high risk also of disability and other adverse events. And I would like to ask both of you, what is your idea about this, and if we should move more to pre-frailty than to frailty, because probably frailty is also an adverse outcome and not a risk category. What do you think about it?
So yes, I would agree that we've thought of pre-frail as the area we should be intervening on for a long time. So most of our intervention studies, the small-scale ones, are targeting pre-frail people. By the time people get into the frail category, at least in the physical frailty categories, often there's not a lot you can do to move them back. I mean, there's been some studies that show, exercise will help and maybe slow the decline a bit, but ultimately you can't put people back into pre-frail or into a robust category. So geriatric assessment, comprehensive geriatric assessment, and more palliative care approaches are the way that I think we have generally treated those patients who are really quite frail and look like they're going to die within a year or two. But I would totally agree that the pre-frail is the what we call the sweet spot for interventions, and most of the targeting should be done in that stage. And then the preventive strategies should be done in robust and pre-frail.
Well, of course, as early you are going to detect and act, your probabilities to improve are the higher. If you put a focus on detecting carcinoma in situ, it's better than to detect cancer in stage 1 than cancer with metastasis. That is quite close. The issue is that as early you go in the chain of events, it's more difficult to assess precisely if you are detecting really people who are at real risk. If you using the same parallelism, if you treat people with metastases, it's very difficult to be fooled in treating cancer. You are pretty sure that you are treating patients with cancer. But if you are approaching people with precancerous lesions, it's not quite clear how many of them are going to benefit. When you approach the same thing for something that is more vaporous, less, the possibility in terms of diagnosis, the sensitivity is not very good and the specificity is very low. So it's possible that you are putting efforts and money in treating people that are not really at risk. Or you are putting money and time in people that is not going to benefit from your effort. We have now recently analyzing data from the Toledo study that those who are categorized as pre-frail, when you follow up them, around 30% have the same outcomes than people who are frail. And 70% of them have the same outcomes of those who are robust. So pre-frail is a gray zone that is very difficult to, with enough accuracy, to detect who is and who is not really in. And the other problem is that they represent 40% of the population. This, in terms of money, means a huge amount of money. So I think that we should remain studying, trying to be more accurate in the definition of the risk and the population we are treating.
Thank you very much. I think that we don't have more time. It's a pity because it has been a great discussion. And thank you for all. Muchas gracias.